Welcome back to another episode of Single Payer Radio. We broadcast our program from the historic Hayburn Building here in downtown Louisville. This show is a project of Kentuckians for Single Payer Healthcare, and we're an affiliate of the Kentucky chapter of Physicians for a National Health Program. We have this program because we believe that healthcare is a human right. We advocate for a national, not-for-profit, single-payer system. Everybody in, nobody out. The views and opinions expressed on our show are those of the speakers and not the station. I'm Mark McKinley, a volunteer with the group. Single Payer Radio can be heard on WFMP 106.5 on Mondays at 2 p.m., Tuesdays at 7 a.m., and Wednesdays at 11 a.m. If you can't pick up our signal, you can live stream us at forwardradio.org. You can also go back and listen to other shows, whether it's Single Payer Radio or other locally produced shows. WFMP is an all-volunteer station. We rely on the community for your ideas and our funding. Join us, forwardradio.org. Mike?
This is Michael Flynn, retired surgical oncologist. Let me begin with the usual disclaimer, which I hope you can hear over the sirens that are going off on the street. Any comments I make during this program represent my personal views and do not represent the views of the University of Louisville or the Department of Surgery. We have a special guest today, Don Henderson. I'm going to let Gene introduce Don in just a moment. The topic today is to discuss issues related to the recognition that in this country, we have a healthcare industry focused on extracting profit from healthcare activities, as opposed to a healthcare system, which exists in most other first world countries, which is focused on providing healthcare to their citizens. So, Gene, you want to introduce yourself and introduce Don, and we'll get the ball rolling.
I'm Eugene Shavley. I'm a retired general surgeon from Campbellsville, Kentucky. Spent most of my career as a rural surgeon. Again, those comments that I make reflect my opinion and not Baylor Regional Hospital nor the University of Louisville Department of Surgery. Don and I are cousins. I think we're first cousins once removed. His mother and I are first cousins, so I think that makes us first cousins once removed. Is that right, Don?
As far as I know.
Okay.
Well, if I get on Ancestry, can I find out?
You can. Well, I have another cousin who's the first cousin, and she's an expert at that.
All right.
And she told me that we were first cousins once.
All right. I'm glad we got that straightened out.
All right. I don't want any conflicts of interest over that. All right. Don has had an extensive amount of experience in healthcare administration, and he's now an assistant professor and director of doctorate in healthcare administration based in Lake Erie College and osteopathic medicine in Brandon, Florida. Prior to that, he's been administrator of several hospitals and several rural hospitals. His undergraduate degree is from William and Mary, and he has a BA in economics and government. He has a MA degree in healthcare administration from George Washington University, and then he has a doctorate in healthcare administration in Central Michigan University. Don, I want you to start off and let you tell us a little bit about yourself, and then what you're doing and what you think about the administrative burden that we have in our healthcare system. And then I have a question for you that's a really important question for the country and for Louisville itself.
Well, thank you very much, Cousin Eugene, and appreciate it, Cousin Dr. Eugene. No, I'm really honored to be here, and I'll do my own disclaimer. These opinions are my opinions and not the opinions of the medical school LECOM that I work for or the Department of Health Services Administration at LECOM. But no, I've had the honor and privilege of being a hospital administrator for almost 40 years. And in my second career, I'm teaching young students at the doctoral and master's level, the field of healthcare administration. And one of the things that's challenging as I go about my daily teaching activities is to talk about the current state of flux of healthcare in the United States. It's a system that's disorganized, it's chaotic, and unfortunately, I think it may get worse before it gets better. And I really admire the efforts of your organization to try to make some sense out of healthcare and also to hopefully return healthcare to a charitable not-for-profit status versus a for-profit status, because the value added there is questionable. But no, I think today I'll wait for you guys to ask me some questions, but I just think I want to talk about some of the things that are happening in healthcare, especially with regard to some of the challenges that we're going to have over the next decade or so, and specifically about some of the shortages in labor and physicians that we're experiencing. The administrative costs are certainly something we could talk about. And then the other issues that are affecting healthcare are factors such as the deterioration of healthcare in rural areas and inner city areas, as well as the budgetary limitations and the potential challenges in government insurance programs, especially Medicare, which is now forecast to have deficits beginning in 2025. So, it's not the greatest time to be in healthcare. That's what I tell my students. But the good news is they're young, they're smart. Hopefully they can help the clinicians who provide healthcare to overcome all of the challenges. And of course, we still have the hangover from the post-COVID area, which has created tremendous dislocation and accelerated some of these problems that we're seeing.
Well, so the headlines in the Courier Journal today is, excuse me, is that there's going to be a new CEO of Humana, and his expertise is in Medicare Advantage and also value-added healthcare. Now, Dr. Flynn just asked me before we came on the radio, what is value-added healthcare? And that seems to be a term that's that CEOs of for-profit health insurance companies and drug companies and administrators seem to use more than doctors. And I'm not exactly sure what value-added healthcare is. Do you have any concept of that, Don?
Oh, absolutely. It depends on what part of the healthcare field that you're trying to look at. Obviously, a lot of what Medicare is the godfather of CMS, is the godfather of value-based care. It's been accelerating since the Obama administration came in. And basically, if you look at it, I kind of look at it as sort of a patient. If you think about it in terms of patient care, the patient's pretty sick, and value-based care is sort of a Band-Aid that we've placed on the patient, which may or may not be able to save the patient's life. But it's basically it's a move away from fee-for-service medicine to pay for quality, the biggest area of value-based care right now is with the accountable care organizations. They're known as ACOs. Right now, there are slightly less than 500 ACOs operating in the United States, and they've had really mixed success. There's a lot of evidence that they really haven't changed healthcare. I think a lot of things with value-based care are, we set up these sort of noble ideals, And I could talk about ACOs more if you'd like, but the problem with ACOs is that it creates a strong financial incentive for physician groups to cut costs. And as everybody knows, there's only so many costs you can cut before you get down to the bone. But I'd be happy to speak more about ACOs or any other aspect of value-based care if you'd like me to.
Don, let me ask you a specific question about that, because my understanding of the ACOs as the for-profit insurance companies or private equity firms identify a clinical practice. And as you said, they figure out ways to cut costs. They use the Medicare database to figure out what the costs are to provide care for the patient population in a clinical practice. And then they try to figure out ways how to cut those costs. And the incentive for doing this is that whatever they don't use to pay for the health care of those individuals in that practice, they get to keep a certain amount of it as profit. And then so the for-profit insurance companies and the clinical practice then make some kind of deal. And so I don't know what the numbers are, but if they save 20% by not providing this care, which has some significant effects on the well-being of those individuals, patients in the practice, and they've got this, the 20%, then they get to keep 40% of that. And then they divide it up in whatever way they make a deal. That's my understanding of it. Is that correct?
Yes, that's absolutely correct. And ACOs have really flourished in Florida, mainly because the most incentive is to take care of the Medicare population. And you've described it very well. I was a hospital administrator in Florida for the past 10 years before taking my professor job. And I saw the impact of this, which is that, part of this, which is kind of, I guess disingenuous would be a nice way of putting it, is that when you have a Medicare population and the practice that takes care of that population, which is usually a large multi-specialty practice, there could be an insurance component, there may not be. But when that large practice takes a group of patients, the patients are assigned to ACOs and they don't even know it. They don't know that they're part of the ACO. There is no disclosure to the patients. So you've got this kind of a secret assignment of a certain number of patients to the ACO. And then the ACO has to balance trying to provide medical care, but also trying to save enough money to make the additional administrative costs worth it. But my own experience has been that we begin to see corners getting cut. The biggest one that I experienced personally as a hospital administrator was that the ACOs will try to convince the patients not to go to the emergency department. And, maybe in most cases that winds up being acceptable and the patients can find treatment either by coming into their own clinics or elsewhere. But it also really puts the patients at risk, especially if they're extremely elderly in their 80s or 90s. It puts the patients completely at risk because if you continue to try to care for the patient in a home environment or a clinic environment and the patient has a medical episode, then there's going to be a delay in care, even if the ambulance can be called. And we saw a lot of that happening. The ACOs were basically playing, I would call it Russian roulette, with the elderly patients. And that's certainly not where we want to wind up in the American healthcare system. We don't want people who are worried and who are elderly to be told by their providers that they can't go to the hospital emergency department. So
the other issue that I remembered from reading about this was upcoding. So that in this Medicare population, if you had pre-diabetes, you got coded as diabetes. If you had a series of relatively minor medical issues that really don't have any effect on your health care, these are all added on so that the actual charges to Medicare, for the care of these individuals was really blown up by all of these coding issues that really didn't have the same kind of, it didn't relate to the normal Medicare population that was being treated by another clinical practice that didn't have all that upcoding going on. Again,
Yeah,
is that a fair statement?
Well, I don't think it's appropriate to call it upcoding. Just be careful here because upcoding is illegal, right? But more
they've gone after them for that, I think.
Yeah, well, I don't know if I want to discuss a specific circumstance, but
Sure.
but capturing the codes is something that the providers and ACOs work a lot at, and they actually have they have physicians that are on staff as well as administrative people to capture every single code that they possibly can, and that does increase their average reimbursement. It's an adjusted, the amount they get paid every year for taking care of a given population of Medicare patients is adjusted upwards based upon the aggregate coding that they can legitimately
Yes.
find. So I don't know that I can say it's illegitimate. I don't have any knowledge of that, but I know from my own experience that the patients will get a lot of probably unnecessary care in order to get them to get the highest coding that they can, and so, for example, I'll give you a specific example. In some ACOs, they always have to do a skin assessment for every single office visit. And if you're really elderly, your skin's going to get blotchy. There's going to be some, tender areas where it's just a part of the natural process of aging. Well, if they can capture that code, which is legitimate for them to do it, but if they capture that code, then, they could get better reimbursement. But the question is that skin, search for the skin of a elderly patient really in their best interest? If they know that that's under control, is that really great healthcare, seeking out codes which may or may not be beneficial to the patient's improved medical condition?
Let me give you a classical example of that. If you have a diabetic and you're 85 years old, the insurance company sometimes will require you to get a study to see if you have peripheral vascular disease. Those are usually called ABIs, where they measure the difference between the blood pressure of the arm and the leg. There's another system that you can do in home called QuantiFlow. Well, most people that's 85 years old have peripheral vascular disease, some mild atherosclerosis. But if you have a diabetic and you do an ABI, and there's no proof that doing this prophylactically changes outcomes, like for example, colonoscopies or mammograms do change outcomes, but not doing prophylactic QuantiFlows. Well, if you are able to do that though, and you can document that they have mild peripheral artery disease, then you can dramatically increase the reimbursement that you get from the federal government on your Advantage plan. And that's being done very frequently. And the computer programs that they have dramatically upcode and put all types of diagnoses on the medical record, which is legitimate. They actually have the disease, but it's usually irrelevant to
their overall health. Yes,
right.
Yeah. Go ahead, Don. Sorry.
No, I think some of the things that are happening here are sort of like we're sort of fiddling while Rome burns, aren't we? Because if there's only 500 ACOs in the whole country, they're not, even though they're some of the individual members that work in the ACOs may be getting excess compensation. That's going to run out. There's only so much that they could do, and so many procedures. One of the big things that happens in ACOs is they convince the patients to put off elective procedures, because they will make more money if those elective procedures are not done. But that will catch up at some point. And as I said, my whole view of the ACO experiment, because it's nothing but an experiment, is that there's only so many shared savings that you can wring out, and ultimately we're missing some of the bigger issues, such as the aging of the population. right now there's about 54, 55 million Medicare recipients, but by the year 2030, because of the baby boomers, there's going to be over 80 million Medicare recipients who are going to be consuming a lot of medical care. So when I say we're fiddling while Rome burns, that's really what's happening. Is the federal government is desperately trying to find ways of cutting costs, but they're really missing the big iceberg that's coming towards us.
Don, let's change.
Okay, can I ask a question just a minute?
Oh, yeah, sure.
So if you were director of CMS and you got all these Medicare patients coming in, and what would you do to try to solve the cost of care?
Well, that's a great question. I think it has to be a multi-pronged approach. Certainly, we could talk about a single payer system, but I believe that medicine should continue to be practiced by private practitioners. Not government sponsored medicine. But the real tough issue, which I don't think people are ready for, is the idea of a universal fee schedule, and that's really what's going to eventually become necessary. Is you've got to get a fee schedule for that to be universal, that's fair. You've got to have a fee. I know you guys are surgeons, but you've got to have one that's fairer to primary care doctors. Right now, only 8% of MD graduates are going into primary care, and only 29% of osteopathic doctors are going into primary care. So you've got an accelerating number of doctors going into specialty care. And so that's got to be taken care of. I think we could talk about the drug industry and pharmaceuticals. Pharmaceuticals used to be only 7% of the national expenditure, but they've now crossed the 12% threshold and accelerating at a rate of 12 to 13% inflation per year in drug costs. And a lot of those are the high end drugs, the ones that are advertised so much on TV. So I think you've got to look at a universal system. I think we could eliminate, I know this sounds controversial, but we could eliminate all insurance companies if we came up with a medical ID card, because in countries like Taiwan, South Korea, and Japan, everybody has a medical ID card that's computer controlled. And basically, when you see a private provider, you basically swipe your card and then the government makes the payment. And I think that we're heading towards something like that.
Don, a single payer system is not a government medicine. It's simply a government insurance program, which is very different from the government system that's run in the UK, that runs everything from the pharmacies to the physician practices to the hospitals.
In the South Asia, in those countries that I mentioned, healthcare is 90% private. It's private. It's run mostly by physicians. But what happens is the government is the insurer, and there's a national fee schedule. But then the provision of medical care is mostly through private clinics and physician-owned hospitals. Is the way that a lot of that care is delivered.
Again, what I'd like to do is kind of switch focus a little bit, and I'd like to make some comments about maternity deserts and get your thoughts about it. We had a lady on, nice lady named Judy Albert, who was OBGYN from Western Pennsylvania. In fact, we did 2 programs with her. And I recently read an article about some rural towns in Idaho, where Idaho has some of the most restrictive anti-abortion laws in the country. The physician, the obstetrics and gynecologists are leaving, and they're having patches of literal maternity deserts where people living in rural communities, excuse me, literally have to drive 90 miles to get to the closest facility that provides that kind of care. And it often involves crossing a state line into a neighboring state like Oregon. The other issue is the training issue. Now, we have the same problem here in Kentucky. And the way the laws are written, I'm going to put my finger up in the air. This is not my middle finger, it's my index finger. And if the embryo at 6 or 8 weeks is about the size of my index finger, and up here, just at my first knuckle, if you do an ultrasound on that, you get a little flicker. And this is a group of cells that, if this pregnancy lasts long enough, that will eventually become a heart at maybe 15 or 16 or 17 weeks. But at 6 or 8 weeks, it's just a group of cells that cause a flicker on an ultrasound. And the way the law is written in Kentucky, if they call this a fetal heart rate, which is, it's not a fetal heart, it's potential fetal heart. And if a woman has a complication of pregnancy where her membranes are ruptured, she's at high risk of serious complications from bleeding or even worse, infection. And if a physician in Kentucky does what's the appropriate medical treatment for that, which is to evacuate the products of conception, they can run into issues ranging from having their license removed to being put in jail. And in many of these red states, I'm curious, the reason I'm asking you this is Florida is in the same situation. I'd like your views about this. The ability to appropriately practice obstetrics and gynecology is forcing these people into conducting medical malpractice. So I won't rant on any more about that, but I'd like to hear your views about the issues of providing good maternity care in Florida.
Yeah, I think, I'm going to sidestep the abortion issue just because I think it's such a volatile thing, but I am interested in and concerned about rural health care. And Florida is one of the only states where there's not a large number of rural hospitals going out of business. Just about every other state, especially those in the Midwest, are losing hospitals right and left. So the hospitals were originally built in the 1950s, 60s, and into the 70s by something called the Hill-Burton Act. And I actually lived in Alabama a few years ago and got to know Lister Hill, who was a famous senator who came from, influential senator that came from Alabama, and it was named after him and another gentleman named Burton. But there were approximately 2,000, I believe, 2,500 hospitals built in rural areas across the United States with the federal funds that were made available. But what's happened since that time is you've had a slow deterioration of the rural economies. Rural economies are largely based, when they're not based on agriculture, they're based on manufacturing. And so with the relocation of manufacturing to other areas or offshore, these economies have lost their wherewithal. And so there's still populations living there, but generally rural populations are declining around the United States, and people are moving more and more into the suburban and urban areas. So the question then becomes, from a larger perspective, not just maternity, but emergency care and surgery and primary care. How can these rural areas continue to sustain their medical system of any kind? And the other side of this, which I mentioned earlier, is that you've got about 40,000 residency spots coming out every year in the medical match that occurs early every year. But you've got 43,000 American medical graduates who are vying for those. So there's just not enough residency spots to be able to even backfill the number of doctors. We have about 730,000 doctors in the United States right now, but there's not enough training going on to backfill. And of course, when there's a shortage, then the rural areas are the ones that suffer.
The other issues, to get back to the red state, the anti-abortion laws, is that the applications to residency programs for an obstetrics and gynecology is going down, and people who are graduating from obstetrics and gynecology residency programs are not going to these states with these really restrictive laws. It's really something. The other thing about rural health, Gene, if I remember correctly, didn't we talk about this at a previous time, that some of these hospital systems and hospitals in rural Kentucky are being bought up by private equity firms?
Well, the nursing homes are. There are several rural hospitals that are owned by for-profit companies, and there's one particularly that is a for-profit excuse me, that's owned by an equity company. And there are several of those hospitals in the state of Kentucky. There are a lot of hospitals in rural areas that are losing their OB. That's even happening in some cities, mainly because they can't support it. Medicaid in the state of Kentucky only provides about 70% of the cost of doing obstetrics. And so our hospital, for example, I think the number is around 70%. It may be a little more than that, of patients who deliver are Medicaid. So every delivery we have, we lose money on. And that creates a financial problem for rural hospitals.
We have some of the worst maternal fetal mortality statistics in the first world.
Yeah, we're like number 10.
Yeah.
I want to go just have one question about the countries that you talked about who still have private medicine, but the government is kind of role is regulation and providing resources. Now, where does that money come from? Is it coming from the government, or is it coming from the industry? For example, in Japan, does Nissan pay into an insurance company, and the patient pay into a company, and then if they get sick, that money that they paid into pays for their medical illness?
Yeah, that's yes. And so what it is that in Japan, for example, I can speak with some knowledge on this because my daughter is living in Japan right now, but every worker, whether they're employed by a business or whether they're employed in a service industry, every worker is required, their employer is required to make the payment into the national insurance system. Now, obviously, elderly people and I guess destitute folks or unemployed, that's covered. So there is universal health care there, but I would say that the employers pay the bulk of that. But remember that in Japan, the percentage of gross domestic product that's spent on healthcare is much lower. That's the ugly truth is that somewhere along the way there's going to have to be a fair and equitable payment system to keep physicians alive and keep them in practice. But the other side of it is that might not be as high for certain procedures. For example, when I was a hospital administrator, I had cardiologists on my medical staff who, if they did a certain vascular procedure in their offices, they could get paid $2,000 for a fairly short procedure. And it was just a fluke of the medical coding system and the way that Medicare paid for these procedures. Whereas if they did a cardiac cath, they might get paid $700 or $800. So the incentive there is the practice is going to follow wherever the reimbursement leads them. And you can always find a way to justify some procedures, especially when some procedures pay 2 or 3 times more than others. So I think the payment system needs to be reformed. It needs to be fair and equitable. I think all employers should have to pay some percentage of this. Now, I can't argue what percent they should have to pay, what percent the patients should have to pay, but there has to be some rationality to the system. Right now, what's happening is that insurance companies pay probably up to twice as much as the federal government pays for Medicare. And like you said, Medicaid in Florida is only 50% of Medicare. So literally the Medicaid patients in Florida only have a payment of 25% of what commercial payment are occurring. So when you've got a system like that, the providers are going to steer away from the government patients and move towards as many commercially private insured patients they can get. But of course, if you have a national fee schedule, that takes that incentive away, and you have universal coverage.
Don, it's my recollection. I haven't looked at this in a while, but I don't think there are any for-profit insurance companies in Japan. Is that a correct statement?
I think there is private insurance available in Japan.
No, I said for-profit. I think because some of these countries allow not-profit, non-governmental insurance companies as opposed to a for-profit insurance.
Right. You may be right about that. I'm not really sure, but I know that in Europe, for example, there are for-profit insurance companies, and there's a private medical system that's operating, external to the government system.
Yes.
But remember, I think universal care ought to be about bread and butter type issues, to get the essential care that people need to prolong their lives, avoid, serious illness. I think that should be a universal right and provided. And then if some private insurance company wants to come along and do a wraparound policy or insure some other risk, that's up to them. But for the great bulk of people, I think we should take care of their basic medical needs. Now, only 1 in 10 Americans is uninsured right now. So insurance has increased for Medicaid, but access has not increased really. So it not only has to be insurance, but it has to be access as well.
Now,
When I first ran into Gene, wandering around the main floor of the library before we went to one of these single payer meetings, we went up and did the meeting, and he presented some data that showed us that in this country, 1/3 of the resources in healthcare are not spent on providing healthcare. They go to administrative costs, profit, advertising. Gene, I'll let you finish this off, but that's really an important bit of information, a very fundamental concern about where the money goes in American healthcare.
yeah, this is gross data. It's hard to get the specifics, almost impossible, and it's changing rapidly. But approximately 1/3, which is almost $1.6 trillion of our healthcare goes to things that are not really healthcare. For example, for-profit insurance, unnecessary care, the pharmaceutical industry. The United States is responsible for half of the cost of drugs in the entire world. And I don't want to be mean to the drug companies because they've done some great things and developed some phenomenal drugs. But at some point, we have to solve that problem. Advertising, we're the only country in the world that allows doctors and hospitals and drug companies to advertise. So there's a phenomenal waste. And if we could just use that money for healthcare and set up a system where everybody's covered, similar to what we were just talking about, then I think we could probably have a universal healthcare system without raising taxes. And everybody, if you start talking about this, that's the first issue they bring up. Oh, we're going to raise taxes. Well, I think it can be done without raising taxes, but That's just my opinion. I think we need to, before we finish here, one of the issues in today's paper was the new CEO of Humana is an expert in Advantage care, and 50% of Medicare patients are now in Advantage care. CMS has pushed this. Can you tell us a little bit about Advantage care, Don, and where do you think this is going to go?
Well, again, I think this is an effort by the federal government to try to rein in Medicare costs. But remember, you've got you're sailing your ship towards this big iceberg, which is, the Medicare trust fund. They keep arguing when it's actually going to run out of money. It's either going to run out of money in 2029, 2030, 2031. Everybody's right now. I think it's 2031 that the Medicare trust fund goes insolvent. So again, I think this is Medicare is trying to do anything they can, sort of like put their finger in the dike. The dike might be leaking a lot of water, but they're trying to put their finger in the dike by doing some of these strategies. But if anything, these don't improve. The cost of Medicare continues to rise. So this is sort of an effort to try and stop it, but it's like trying to stop the tides. It's going to happen. Now, there is good news in terms of after 2030, maybe around 2035, healthcare expenditures are going to come down, but that's because the baby boomer population is going to age out and go and pass on. So there is this big tsunami coming for the Medicare system, and I admire trying to. I mean, at least they're trying something. They could keep it going, but remember the underlying factors are there: population growth, the growth of technology. Technology is not regulated at all in the United States, and technology continues to go forward. It's good in many ways, but one of the issues we had was that once you become a robotic surgeon, we had robotic surgery at our hospital, like a lot of hospitals do. The physicians wanted to do every case as a robotic case, because it's easier for them and they feel more in control. But there's no reimbursement for robotic surgery for hernias, for example. The hospital loses money on every one of those cases. So technology is a double-edged sword. And cost of drugs are accelerating. Labor costs are really shooting up for hospitals right now because women have other career choices, and to entice them to remain in the nursing workforce under tremendous stress is one of the things that's causing nursing wages to rise. Then you've got a physician shortage. So of course, when there's a physician shortage, physicians can demand more income, especially specialists. So their wages are going to rise. So we've got a lot of things happening kind of under the surface of the ocean. So I think that this is, maybe a noble effort on their part, but I really don't think that Medicare Advantage is really, it may save the federal government some money, but not really a lot.
I want to ask, you want to go first, Gene?
You mentioned the waste of doing a hernia with a robotic surgery. Are there hospitals who are telling surgeons you can't do that? We're losing money.
Well, when I was sitting in the chair, I would go to the physician every time and fuss. But I can't practice medicine. Was a hospital administrator, not a doctor. So you just have to kind of wear them down after a while and complain enough, and you can get it. It's persuasion is the only tool we have in our toolbox. But using peer pressure is another way of doing it. Of course, is you convene a meeting of the surgery department. You tell us, let the chief of surgery be the bad guy in that case. But this technology continues to accelerate. I'm sure you all have heard of the Watchman procedure. You probably heard of that. That's a device that's implanted. You probably heard of the TAVRs. We had all of that available at my previous hospital, but all of those lost money. But then the physicians were incentivized to put those in. One of the things about TAVR, and maybe I'm stepping on toes here, but TAVR really doesn't extend somebody's life, but maybe 6 months to a year. And, you can put a TAVR in and spend $50,000 on a patient, but then the hospital doesn't get reimbursed. And if you close your hospital over doing too many TAVRs, then what have you really achieved? I can't make that decision for an individual patient. I guess if it's my family member, they will find a way to get a TAVR, but the reimbursement is just not there. And the cost of technology is killing many hospitals, especially rural hospitals that don't have enough commercial patients to offset the cost of the losses under Medicare.
Well, Don, I came to Louisville back in the 70s, and in the late 70s, I was chief of surgery at one of Louisville's downtown hospitals for 2 terms, and it was one of the hardest jobs I ever did. We had an organization called the Surgical Care Appraisal Committee, and that the issues of doing a robotic versus an open hernia, all of those issues were addressed at that committee. And there were surgeons, there were administrators, there were people from other specialties, and it was a really good way to address those issues. In your experience and as a hospital administrator, did you have a similar sort of integrated activity like that with the medical staff? Because today, the way things are done, unfortunately, most of these hospitals have now become healthcare systems, and they've absorbed a whole bunch of medical practices, and the medical practices don't have the independence they had way back when, because they get a check from the institution. And a lot of that balance of power, it seems to me, has been lost. I wonder what your thoughts about that are in terms of having physician practices managed by hospital systems.
Yeah, I think so many specialists, especially over on the general surgery side, so many specialty groups are not able to function on their own. So I think a lot of the acquisition of medical practices has been sort of a necessary evil for many of the hospital systems. But again, you can't, under every state law, you can't tell physicians how to practice medicine. So you can try, but it's up to them. They have the patient's life and well-being in their hands, and so you can't really tell them what to do. You can complain about it. Yeah, we've used committees, we've used lots of different things, but ultimately physicians are going to do what they want to do. One of the big things we haven't talked about is the fact that so much of the elective procedures are now being moved to physician offices, right? Because almost every large physician practice that's a surgical practice is now moving some of the cases to ambulatory surgery centers, which they may or may not have their own financial stake in. And I think that not only are healthcare systems and insurance companies buying practices, but also Wall Street is also buying practices and moving a lot of the care from the hospital environment to a corporately owned surgery center. That's happening.
Well, I'm always curious about how that works, because you've got these private equity firms buying up as outpatient surgery centers. You're absolutely right about that. But I don't understand how the finances work, because most of those private equity firms that buy nursing homes, they claim that they're going to cut the cost, which basically means they reduce the staff and they medicate the patients, and they do this for 4 or 5 years and sell it and move on to something else. So I don't know how these do you have any idea, Gene, how these outpatient surgery centers that are owned by for-profit private equity firms, how does that work? How do they make money as opposed to having an outpatient surgery center that's part of a hospital system or something like that?
Well, the usual way is they'll take a system that's not doing too well, and they will start trying to increase the income, by increasing the coding, etc. And I know of a situation where the equity company borrowed a lot of money, and then they closed it, and then the money went to the finance people who were financing it. Yeah. Now, I know of another situation. I just talked to a doctor about a month ago about this, who works for a for-profit a hospital, and he's part of a large system which is owned by an equity company. And I asked him, what's going to happen to this hospital group? And his thought was that the equity group would take the hospital back public, and the money that they made from doing that would go to the people who had financed put their money into the equity system.
Don, we're down to the last 4 minutes. Let me ask you a question that you may not have an answer for, but I'm going to ask you anyway. Gene, Mark, and I are here because we believe we should have a single payer Medicare for all system in this country. And I've listened to your comments in your last program and in this program. I have a sense that you sort of have a similar feeling about the way this would, the best way to deal with the healthcare system in this country. As a reality factor, what do you think the likelihood of anything like that happening anytime soon with the partisanship that exists in Congress and in this country as a whole? And we're probably going to be ending up toward the end of the lollipop after you answer that question.
Well, I think there has to be a cataclysmic event. Every politician is going to kick the can down the road. Obviously, there are strong forces in industry, pharmaceutical industry, technology industry, Wall Street. Everybody's going to kick the can down the road until there's a cataclysmic event. One part of that might be the collapse of the Medicare trust fund. The Social Security trust fund is not far behind. One might be some issues regarding the way that the whole system comes together, with either the physician shortage getting too acute. That can happen. There's a nursing shortage that's occurring. So there would have to be some sort of a cataclysmic event that the politicians could not run away from. I think it would be far better for the American system for us to face these issues now, have adults in the room and have a conversation about it. As much as people may or may not like the previous Democratic administrations, everyone in Washington knows that the system is headed for catastrophic events. So they'll put it off till they can't put it off anymore. But I think it's better to do some pre-planning. I know I only have a few seconds left, but in Korea and Japan and in South Korea, Japan and Taiwan, Taiwan actually came to the United States to study the American healthcare system, and they did a massive reform of their healthcare system that was partly based on the private delivery of medical care, which we have in the United States, but then they took the best aspects of how a national payer system could actually work. So my advice is to please let's work on this before it becomes too late, because if there is a catastrophic disruption, that's going to not be in the best interest of the patients that are, especially the elderly patients that receive Medicare up till now.
Don, I want to thank you very much. This has been an excellent program. We probably will be sending you a message in about 6 months to bring you on and talk again about.
Last Wednesday, that was October the 11th, 2023, labor representatives, healthcare advocates, and retired persons gathered down at the Humana headquarters at 5th and Main in Louisville and spoke out against the privatization of our Medicare system and advocated for a healthcare system that puts patients before profits. One of those attending was Harriet Seiler. As many listeners know, Harriet is a longtime officer and steering committee member of Kentuckians for Single-Payer Healthcare. We hope to have other reports and voices from that rally on upcoming episodes of Single Payer. In the meantime, I'll leave you with Harriet.
We want to take the profiteers out of our system. We want doctors to be fairly reimbursed. We want hospital staff to be properly paid.